Good morning, respected faculty and dear delegates. Welcome to today's session on hypertension in children. I request our secretary, Dr. Dinesh Kumar Goyal, to please start the session.
Thank you, sir. Thank you, Dr. Jason. And good morning, everyone. And on the behalf of HYPERTENSION, I welcome you all in this wonderful session on eNephro master classes. Today's topic is hypertension and the renal issues, basically. And the speaker is Dr. Vijay Saha. The expert is with us, Dr. Ankit Mangla. And the chairperson for the session is Dr. Sunil Kumar Sehgal, sir, the president, IIP South Delhi. Now, I would request to give one minute welcome address by Dr. Ajay sir, and then followed by the introduction by Dr. Neha Bhandari ma'am. Thank you, sir. Over to you.
Thank you, Dr. Dinesh. We welcome Dr. Sunil Kumar Sehgal, President, IIP South Delhi branch, and Dr. Ankit Mangla, who will be the expert of the day, and ABHIJEET Saha sir will be the speaker for the day. And we are really thankful to Dr. Neha Bhandari, who had been organizing this session. And also today we have auspicious beginning of the pre-conference workshops of prestigious pediatric conference of North India. Many of residents who are also delegates in this group have joined for those workshops. So today's attendance may be a little less, but still they can always watch the presentation later on the YouTube. So without wasting much time, I request Dr. Neha Bhandari, ma'am, please introduce the expert and the speaker. And I request Dr. Sunil Kumar Sehgal, sir, to say a few words before we begin. Dr. Sehgal, sir.
Should I say? Yeah, hypertension, I believe, is a very important problem. It's on the rise in children, and initially it used to be mainly secondary. Now primary hypertension is also on the rise. In fact, a survey was done in school by a friend from Maulana Azad Medical College, and he termed the hypertension as Chupa Rustam. So I think it is something we should look into in our clinics, and at least have one recording whenever we can, whenever we do a routine checkup of a child. And we should all obviously have some charts, by which we can refer according to the age of the child, and the cuffs also are important. So over to Neha to introduce the speaker. Thank you.
Thank you very much, sir, and welcome, sir. So we welcome everyone. Today's attendance, yes, as Ajay sir has said, it will be little less because all of our participants have gone for workshops. But nevertheless, hypertension is a very, very important topic for pediatrics as well as for pediatric nephrology, critical care, all point of views. And for discussing this topic, we have expert today as Dr. Ankit Mangla. So, Dr. Ankit, I'm very happy to say that we are our alma mater is same. Both of us have our initial training from Gangaram Hospital. He's MD Pediatrics and he has done fellowship in pediatric nephrology as well as he has done fellowship in pediatric critical care. He is currently a senior consultant and running his own hospital, which is Hope Hospital. He is also heading pediatric nephrology and critical care there in Jaipur. He has multiple publications as well as written a lot of chapters in pediatrics as well as pediatric nephrology. Dr. Ankit, welcome, and looking forward to have insights about hypertension from you. Then I would like to welcome our speaker. He does not need any introduction, Dr. ABHIJEET Saha. I would say I have never been directly a student of him, but he is a mentor for all of us. One of the pioneers of pediatric nephrology in India and Delhi. He's the first IPNA fellow at AIIMS. He has also done fellowship ISPD from Heidelberg. He has also been a fellow at RCPCH, Ghosh, London, at fellow at ISN, NUH, Singapore. He has also established the Division of Pediatric Nephrology at Kalavati Saran Hospital and also started first DM course in Pediatric Nephrology at Central Health Services at Kalavati Saran Hospital. He is also the course director of Pediatric Dialysis and Therapeutic Apheresis Module for Emergency for PGs and Fellows. Sir has written so many publications. Sir, welcome you all. Welcome from all of us to you and waiting to hear from you about hypertension. Over to you, sir.
Thank you, Dr. Neha. Thank you, esteemed experts and office bearers of IAP.
Sir,
And
can you please increase your volume from the system? Volume is little less.
volume is full मेरे system में तो.
Okay, great.
Can you
Please
hear
go
me
ahead.
now? Is it audible? Yeah. Uh, and I will share my slide.
Yes.
Can you see my slides?
Yes, sir.
Can you see my slides?
Slides are visible, sir.
Visible, sir. Visible.
Yeah. And I'm audible also?
Yes, sir. Please just keep near the microphone.
Yeah. Thank you so much for inviting me for this talk on hypertension recent guidelines. So a couple of things before I start the talk. Slides might be more, so I'll stop at 30 minutes to accommodate the questions. And I will not be dealing into great details into ambulatory blood pressure monitoring and all, because I think that's a separate lecture. And I've kept the presentation simple, directed towards postgraduates and practicing pediatricians.
Sir, don't worry, you can take 10 to 15 minutes more.
Yeah. So overall, if we look at the, as Sir told, Dr. Sehgal has told, the prevalence of hypertension, as we are more aware and as because of the lifestyle changes and all, is increasing. It is increasing globally. Now, what is important to realize is that in Africa and in South Asia, including India, the prevalence of hypertension is nearly doubled that of the global prevalence. So the global prevalence is around 4%. However, in sub-Saharan Africa and South Asia, it is around 6.9%, and this is from a recent meta-analysis published in JAMA Pediatrics 2025. Another important aspect is that obesity or overweight has significantly higher prevalence of hypertension as compared to those who have a normal weight for sustained hypertension. And you can see obesity, the prevalence of hypertension is to the tune of 16%. So this is really alarming. Now, this is from a meta-analysis which was done globally. Now, if we look at some of the studies in India, so from Nagpur, one of my students, Dr. Amar Taksande, he conducted a study and found around 3.2%. This is a little, say, around 10 years old data. So variable between, so if you can see from India also, from school-based studies and community studies, you can see that somewhere between 3.5 to 7% hypertension is getting detected. And probably this is a tip of iceberg. Now, if we look at the data, even from Western countries, there is significant underdiagnosis of hypertension in children and adolescent. And again, a study from JAMA published in 2007 showed that in the first or second visits, only 26% of the patients who had documented hypertension were diagnosed. It was only later on when they repeatedly visited the ER for certain other things, they got diagnosed. And for pre-hypertension or elevated blood pressure, what is now being told, only 11% met the diagnostic criteria. And I believe that in our country also similar is the situation. So, so the message is that, as Sir told, that blood pressure measurement is important. Now, primarily, we dwell with the clinical practice guideline for screening and management of blood pressure in children and adolescent, which was published in 2017 by the American Academy of Pediatrics. These were revised clinical practice guidelines after many years. And myself and Dr. Rajiv actually, and I just contributed a small portion of it from ICH Kolkata. We also published an update because this article, the AAP article was quite lengthy. We also published an update on the important changes which were brought into the guidelines, and students can go through this update in Indian Pediatrics 2019. Another important thing which I will dwell with is the very recent, so the last month only, the practical approach to evaluate and manage hypertension in youth is published by the International Society of Hypertension, and this is also a position paper. And Professor Joseph T. Flynn and our own Indian counterparts working abroad, Dr. Rahul Chanchalani and Dr. Manish D. Sinha, both of them an expert in hypertension, are the co-authors in this paper. So I'll dwell with some of the newer aspects from this paper as well. Now, as this paper talks about that why pediatric hypertension is important, because pediatric hypertension leads to development of, if untreated, leads to development of target organ injury. And once these children progressed, if untreated, progress to adult hypertension, has got a significant adverse cardiovascular outcomes, including adverse kidney events, and overall lead to systemic burden and increased cost and morbidity and mortality. And that is why evaluating and diagnosing hypertension in childhood is extremely important. This was also evident by one of our recent thesis, MD thesis, which we were actually doing for children with infrequently relapsing nephrotic syndrome. But what we found that even in infrequently relapsing nephrotic syndrome, good 30% of the children were hypertensive, and interestingly, those infrequently relapsing nephrotic syndrome in whom the parents, either of the parents, were hypertensive, were more likely to be hypertensive. So the role of essential hypertension or primary hypertension in adults in the parents is extremely also important marker, and that will also lead to subsequent morbidity and mortality in children with hypertension. Now, in whom do we annually in children who are more than 3 years old, and in children who are more than 3 years, on every health encounter, if these children are obese or already on medication for increased blood pressure, they have any history of renal disease, any history of aortic arch obstruction, coarctation, or diabetes. In less than 3 years of age, any history of prematurity of low birth weight, it is very evident that those who are born premature or those who are having low birth weight, they are likely to be more hypertensive later on. Those with congenital heart disease, children with known neurological malformation or renal malformation, all patients with CACT are at risk of progression to chronic kidney disease and hypertension, solid organ transplantation, malignancy, bone marrow transplant, treatment with medication known to raise blood pressure, systemic illnesses associated with increased blood pressure, tuberous sclerosis. So these are all candidates for measurement of office blood pressure. Now, another important aspect is that how for postgraduates specifically, not only for postgraduate, even for those who have done only MBBS and looking at children in the emergency department, it is extremely important to measure blood pressure correctly. So one should be measuring the blood pressure in right arm with an appropriate cuff. Why right arm? Because if you are measuring the blood pressure in left arm, at times coarctation, rarely though, coarctation of aorta might be missed because blood pressure might be abnormally low in left arm. So that is why right arm is by dictum, we measure office blood pressure in right arm with appropriate size cuff. And if we need to measure BP on 3 different occasions, and then we compare based on the BP centile charts, which is again based on age, gender, and height. All 3 parameters needs to be taken into account. Now, as told in the beginning only, the cuff width and length is extremely important. And this is one of the sore points even in large public hospitals, as to where you see 100 and 200 patients in OPDs, availability of blood pressure cuffs of each side. So newborn width and length is different, infant size is different, child is different. So you can roughly remember that the width and length, if you double then if you double the width, the length would be appropriate. Otherwise, the dictum is that the cuff bladder length should be around 80 to 100% of the arm circumference, and the bladder cuff should at least be around 40 to 50% of the arm circumference. So these are some of the basics for postgraduates who are measuring blood pressure in whatever situation. Now, the 2026 updated guidelines, or the new guidelines of the International Society of Nephrology, has this International Society of Hypertension has this very important table, and I thought I'll share with you. It talks about inaccuracies of blood pressure values caused by incorrect technique. So there are various aspects: patient preparation, patient positioning, room characteristics, device cuff characteristics, measure techniques, and observer characteristics. All these, if there are problem in these techniques, then either there will be underestimation or overestimation of blood pressure. So you need to be very careful, and you need to be aware of these circumstances. And if one of the important things which I would highlight from this table, if the cuff is if you are using a small cuff size, then the blood pressure will be high. And if you are using a large cuff, then the blood pressure will be low. So you need to be, because many times it happens now, the appropriate side cuff is not available, to let us take from a larger cuff or a lower cuff. So apart from these things, you need to be careful regarding other. Coming to the measurement of blood pressure. So quickly about the auscultatory methods, we know mercury sphygmomanometer, aneroid is the auscultation method, oscillometric devices, and APVM. These are the various methods by which you measure blood pressure. Most of the outpatient department or in the ICUs, you will find oscillometric devices, and each has got an advantage and disadvantage related to it. Mercury sphygmomanometer is the gold standard. However, there are environmental concerns related to mercury contamination, and that is why most of the time it is not available. Aneroid is ecologically friendly alternative. However, it is less accurate than the mercury, susceptible to reading, and it requires frequent calibration. The advantages of oscillometric method is that it is less susceptible to error and bias. However, again, validation of devices is needed before you start using it. Coming to the updated American Academy of Pediatrics guidelines for the diagnosis of hypertension. So the more than 13 years is aligned with the adult guidelines of Americans Hypertension Society. The normal blood pressures in more than 13 years is less than 120/80. And then there are three categories: elevated blood pressure between 90th percentile to less than 95th percentile, hypertension stage 1, more than 95th centile to 95th centile plus 12 millimeter of mercury, and stage 2 hypertension, which is 95th centile plus more than plus 12 millimeter of mercury. There are European guidelines also, which say the stage 2 hypertension is 95th centile plus more than 5 millimeter of mercury. But what we follow in our country is the AAP guidelines, and one should be checking all the blood pressure based on the AAP guidelines. Now, another very important aspect which I would like to highlight is that all patients, especially all all large public hospitals and large ERs where we see a lot of patients daily should have this screening BP value pasted in the emergency. So these values have been again given by the American Academy of Pediatrics. And these are charts which are based on 90th centile and 5th centile of for height. 90th centile for blood pressure and 5th centile for height, and has got a negative predictive value of 99%. What it means is that if the blood pressure of the child is below these systolic and diastolic blood pressures, then there is 99% chances that the child is not having hypertension. So this is good for screening. This doesn't mean that you, if there are symptoms, you do not measure the measure the blood pressure by auscultatory method, but at least you would not miss diagnosis of hypertension in the busy ER. Also, there is an algorithm which needs to be followed once you diagnose hypertension. So you need to measure the BP twice by using auscultatory method. If you find that with an oscillometric device, the child is having hypertension. Very briefly about 1 or 2 slides about ABPM interpretation. So ambulatory blood pressure monitoring is indicated in certain situations, which I'll dwell with. Now, there are certain parameters on which ABPM data interpretation is done. One is the mean blood pressure. Other is the blood pressure load. The third is the nocturnal dipping. So the BP load is the percentage of reading above 95th percentile. Normally it should be less than 25%. Then nocturnal dipping, which is the mean awake BP minus mean sleep BP divided by mean awake BP into 100, and it should normally be about 15%, and non-dippers if it is less than 10%. So this is about briefly about ABPM. Now, why ABPM is important? There are two important diagnoses. One is the white coat hypertension, because many children may become apprehensive and they might show an office BP which is higher. So ABPM helps in diagnosis of white coat hypertension and masked hypertension. On the other hand, there might be children where office blood pressure might be normal, but they may be having true hypertension. So this by ABPM, you can distinguish whether the child is having whether a child is having masked hypertension, white coat hypertension, true hypertension, or the child is truly normotensive. And there are certain other classification system based on the ABPM monitoring. And these are basically based on the charts, which in details I'll not dwell with. However, it is important to know even for postgraduate as to when ABPM is recommended. So conditions where you should be considering ambulatory blood pressure monitoring is secondary hypertension, children with CKD or structural abnormalities, diabetes, those with solid organ transplantation, obesity, obstructive sleep apnea with hypertension, aortic coarctation, certain genetic syndrome, those who are already on hypertension. So these are the certain diagnoses where you might need ABPM. Now coming to the common causes of hypertension. Now they can be divided based on the age. So in neonatal age group, usually renal artery or venous thrombosis, renal artery stenosis, congenital abnormalities, or coarctation of heart are the common ones. Beyond that, there are two important causes of hypertension, especially secondary hypertension, apart from obesity and primary hypertension. One is the renal parenchymal disease, other is the renal artery stenosis. The other less common causes would be endocrinopathies, which occur more in older patients 1 to 6 years of age, and also primary hypertension, which usually occurs maybe after 5 years and definitely common in adolescents more than 10 years of age. Now, there are situations where hypertension can present as a life-threatening event. And in neonates, it can be because of coarctation of aorta or renovascular hypertension. Young child usually may have a renal parenchymal or a renovascular cause, rarely an endocrine cause. And in school-going children, it is primarily the renal parenchymal disease and renovascular causes, which can present with a life-threatening cause of hypertension. Just a slide, because I'm not going to dwell in detail about endocrine causes. There are a whole lot of endocrine causes of hypertension, which could be adrenal, pituitary, thyroid, and parathyroid levels. So if at all you find that there is severe hypertension and you are not finding a cause in general evaluation, then you must think of endocrine causes of hypertension as well. Most of these patients would have some of the acid-base abnormalities, metabolic alkalosis, hypokalemia, and things like that. There are pointers towards it. Now, what are the red flags for a possible end organ dysfunction? So hypertension can present as hypertensive emergency, hypertensive urgency, hypertensive encephalopathy. These are three terms with all the postgraduates should be well versed with. So hypertensive emergency means that there is end organ damage in terms of either CNS or eye abnormalities, retinal involvement, or acute kidney injury, pulmonary edema. These are some of the end organ dysfunction. Urgency means that there is severe hypertension enough, but there is still no end organ damage, or the manifestations of end organ damage is still not started. Encephalopathy means that there is CNS abnormality in terms of either seizures or focal neurological deficit or coma. These are some of the features of hypertensive encephalopathy. So what are the red flags? If you find that the blood pressure is elevated and the child is having nausea, vomiting, headache, upper motor neuron signs, semiparesis, monoparesis, loss of vision or blurring of vision, seizures, altered sensorium, reduced GCS on a GCS coma scale. Acute on chronic hypertensive patients, if they have papilledema, on examination, if you find that there is cardiomegaly, gallop rhythm, pulmonary features of pulmonary edema, these are all red flags for hypertension. Now, based on whenever you see a child with hypertension, in the ER itself, you should look for certain history and physical examination in details. In renal parenchymal disease, usually you will find features of glomerulonephritis. That means anasarca, hematuria, apart from high blood pressure, they may have oliguria and red-colored urine. On examination, apart from anasarca, they may have a palpable mass in abdomen. They may be short stature, pallor. They may have thrombocytopenia. On investigation, urea creatinine will be raised. And on renal ultrasonography, you might find some abnormality. Renovascular hypertension, neonatal history of umbilical artery catheterization, abdominal bruit, abdominal mass, cafe au lait spots, neurofibromas. These are some of the physical examination findings. In this case, you will require definitely a Doppler, serum, renin-aldosterone, CT angiography and all. And rest endocrinopathies are rare disorders. If suspected, then again, the renal aldosterone levels, cortisol levels, adrenal imaging and all are required. For primary hypertension, calculation of BMI, taking blood pressure of the parents, the sedentary behavior, weight gain, snoring, acanthosis nigrans, HbA1c on investigation, fasting lipids on all. These things are very important. So this is extremely important for postgraduates who are looking at. Then there are certain genetic disorders which can present with hypertension, like neurofibromatosis, tuberous sclerosis complex, Turner syndrome 1, Pin-Landau, congenital adrenal hyperplasia. And there are different physical findings which you should look for, like cafe au lait spot and all. In these patients, facial angiofibroma, shagreen patch, webbed neck in Turner syndrome, renal angioma, cerebellar hemangioblastoma, and other things in von Pin-Landau. So these are some of the markers with children with hypertension. I think with this, I'll quickly discuss one or two cases if time permits. So this was a around 10 years old male who presented with edema, and this is actually a bottle. We just asked the patient to collect urine in the bottle, and he had this bottle which exactly looks like a cola color. So actually this is a urine of a patient which is a cola colored urine. So this was a child who presented with periorbital puffiness for headache, and headache for 4 days, alteration of sensorium, oliguria, and smoking urine. He had pyoderma 2 weeks back. There was no history of fever, rash, no joint pain. He had pedal edema, facial puffiness. His blood pressure was extremely high when he ended in the ER. The picture you saw was much later when he presented to the ward. In this child, despite hypertension, forelimb BP was not taken in the ER. The child had papilledema. The chest and CVS were normal. Some post-pyoderma pigmentation was present. So based on these charts, you can see that the child was having stage 2 hypertension. And on further investigation, urine protein was 2+, dysmorphic RBCs was present, acute kidney injury was present, though luckily hyperkalemia was not present. C3 was low. Anti-DNase B was raised 2000 units per ml. So anti-DNase B is a marker of post-streptococcal glomerulonephritis, either ASO or anti-DNase B. They both point towards post-streptococcal infection. C3 was also low. So this was an hypertensive emergency because the child had alteration in sensorium. And so PSGN can have a number of atypical presentations, and one of the atypical presentations would be hypertensive emergency. At times, we have seen even patients with PSGN presenting with hypertension and loss of vision because of reversible post-leukoencephalopathy syndrome. Now, I want to want the attention of the postgraduate students on this decision-making tree. It is extremely important, as I told you, to distinguish between hypertensive emergency and hypertensive urgency. Why? Because the drugs which you will give to manage these patients will differ. If there is hypertensive urgency, you may get away with IV medications, and you may give oral medication if the patient is able to tolerate. However, patients with hypertensive emergency will have end organ damage, and that is why a controlled IV infusion is required, because again, a rapid reduction can result in ischemia of the brain, retina, spinal cord, and kidneys. And that is why a controlled decline in blood pressure is extremely important. And how controlled? So of the planned blood pressure, so you must come to 95th centile for the age in around 48 hours only. So the first 6 hours, you will decrease around 25%. After this, say 16 to 48 hours, another 30% reduction, and only beyond 48 hours, you will come back to the 90th centile. So this is extremely important. Otherwise, the child would have end organ damage. And that is why for doing a tight titration for a decrease in blood pressure, either nitroprusside or labetalol should be used. We primarily use most of the times IV labetalol or nitroprusside for in most of our patients. So this is a true case. We started with nitroprusside infusion in this case. Remember that the saline bottle and the tubing needs to be covered with the carbon paper because it is light sensitive. Now look at the BP reduction here. So approximately if we take around 10 years old child, and if we take that the 95th centile for this child would be somewhere around 120, 130, that means from 190, you need to decrease in 48 hours 60 millimeter of mercury only. What it means is that 25% of that means 15 millimeter of mercury. So the initial 6 to 8 hours, you will decrease the blood pressure only by 15 millimeter of mercury, and the rest around 95th centile over next 48 hours, and oral medication you will start only after, say, after 24 to 36 hours. This child, because was the primary cause was PSGN, was given furosemide, and later on was shifted to amlodipine as well. So there are certain important aspects of managing severe hypertension. You must understand which measure of BP should be used. From which measure I mean to ask you about systolic or diastolic. So most of the experts and guidelines would say you should be looking at the systolic blood pressure in these cases. What constitutes severe hypertension? Stage 2 hypertension. So because there are European guidelines, there are other guidelines, and there are AAP guidelines. So for most of the experts would recommend you that you use the AAP guidelines. That means blood pressure 95th centile plus either 30 millimeter of mercury, or you can say stage 2 hypertension is that 95th, more than 95th plus 12 millimeter of mercury. I have already explained about distinguishing between hypertensive urgency, emergency, and encephalopathy. Now, another important aspect when you are managing severe hypertension is the evidence of prior hypertension. Now, some of the PICU papers have recently come up that even rapid reduction in blood pressure in children with hypertensive emergencies is safe enough. There are some controversial papers, but what they have missed out is that whether you already know when a child is presenting whether this patient is having prior hypertension or not. And most often in low middle income countries, it is very difficult to know whether this child is hypertensive only for last 4 or 5 days, or the child is hypertensive for last 2 or 3 days. And we exactly do not know the autoregulation business of the brain because of hypertension. So one should be very, very careful in bringing down blood pressure unless you are very sure that the hypertension has started in, say, last 4 or 5 days only. You should target a reduction in blood pressure gradually only. And how safe can it be? How slow reduction of severe hypertension is achieved? I have explained you just by this example only. Then responding to relative hypotension. Now, if at all you have targeted overzealous hypertension, reduction in blood pressure, and if a patient becomes hypotensive, then you have to treat that hypotension by normal saline, either 5 ml per kg of normal saline or 10 ml per kg of normal saline. If you do not treat this hypotension, again, the end organ damage will be severe. And finally, reaching the final systolic blood pressure target before commencing oral treatment. So the evidence suggests, the current evidence, if you look at the recent papers, both in Journal of Hypertension by the International Society of Hypertension and other review articles in pediatric nephrology, they would suggest that only after, if you have end organ damage, start oral medications after 24 hours. And this is a schematic diagram, which is, I thought is very nice to share with you all. So look at how the blood pressure is being decreased in a child with severe hypertension. So if this is the normal blood pressure range, the child presents to you with severe stage 2 hypertension. So the initial decline for the first 6 hours is only 25%. And then gradually over 24%, over 24 hours, only you tend to start oral medication, and you bring down the blood pressure to below 95th centile only after 48 hours. So this was about the first case. Quickly, I'll go through the second case. Again, this is a true case. This child presented with multiple GTCS in the ER itself, was given midazolam, was found to be hypertensive. In this case, the senior resident was diligent and took 4 limb blood pressures, which was normal. The other general physical examination was non-contributory. So what are the possible etiologies and what symptoms you should look at if you get that severe hypertension in the ER itself? So ask for palpitations, sweating, flushing, exophthalmos, tachycardia, diarrhea. And the possible etiologies are written here. Any palpable mass on examination. So this child, this diagram shows a child with Wilms tumor. This is not for this child, but for another child, which we saw. Any presence of fluid overload, abdominal bruit, moon facies, truncal obesity, stria, weak peripheral pulses, low blood pressure in extremities, bradycardia. So these are all symptoms which patient might not tell you, but you will have to extract and you will have to examine the patient. So rest of the examination was normal. Gradually, this child also, we started nitroprusside. Gradually, the blood pressure was controlled. The child was put on oral medications. What is important here? The child is requiring multiple medications for control of blood pressure. So again, that is a red flag for a secondary cause of hypertension. And on ultrasound, you find that there is some discrepancy in the kidney size. Why the right kidney was 9.6, the left kidney was 7.4 only. That means a small kidney. So we suspected that this child might have a renovascular hypertension. The plasma renin activity was increased. And on CT angiography, you find here that on this side, the renal artery is seen, the kidney size is normal. On the other side, the kidney size is smaller and the renal artery is also not seen. So this was renal artery stenosis. So this was renovascular hypertension, another important cause of hypertensive emergency. So there are a whole lot of causes, including fibromuscular dysplasia, some syndromic causes, Takayasu's vasculitis, like Takayasu's disease, extrinsic compression, and all. So when will you suspect renovascular hypertension? If there is very high blood pressure, cerebral symptom, cardiac failure, facial palsy, hypertension not controlled with 2 or more drugs, diagnosis of a syndrome with a high risk of vascular disease, signs of vasculitis, renal artery catheterization, thrombosis, transplanted kidneys, bruise heard over renal arteries, raised peripheral plasma, renin or with moderate hypo. So these are all markers of renovascular hypertension. And in one series, if we look at overall renal hypertension in emergencies, renal origin causes are most important, and the clinical manifestation includes CNS, CVS, and eye abnormalities. If you have coming to the therapy of hypertensive emergencies, so you have IV medications, as I told you, labetalol, nitroprusside. We are now using also hydralazine. It is now available. Hydralazine, both IV and oral, is available in at least in Delhi. So we use hydralazine at times, labetalol and nitroprusside. And for hypertensive urgency, you have other medications like clonidine, oral hydralazine. Again, we have minoxidil. And then depending upon the etiology, you can use. So principle of treatment is to bring down the blood pressure to safe levels, which is below 95th centile. When you are dealing with office hypertension, that is, and more so primary or essential hypertension in children who are obese, then the non-pharmacological treatment is extremely important. So diet, which is known to cause decrease in the blood pressures is very important, along with moderate to vigorous physical activity. So appropriate fruit and vegetables, low fat products, whole grain products, fish and poultry. So this all constitute diet which is appropriate to stop hypertension, also known as DASH diet. So this is extremely important. And overall, the literature, even the newer guidelines, the 2026 guidelines suggest that if you follow all these, approximately 5 to 8 millimeter of mercury decrease is possible in 3 months' time. For office hypertension, these are the different categories of drug which are available. And the dictum is you increase the dose of one drug to optimal, the maximum dose, and then only add if you are dealing with office hypertension. Then there are specific recommendations. If there is primary hypertension, you have a choice of calcium channel blockers, ACE inhibitors, and thiazides. Acute glomerulonephritis, to begin with furosemide and calcium channel blockers. Remember that most of the acute glomerulonephritis would have hyperkalemia, so do not use upfront ACE inhibitors or ARBs in management of hypertension of these patients. Those with renovascular hypertensions are initiated with the calcium channel blockers and or beta blockers. Additionally, you can use prazosin, clonidine, hydralazine, or minoxidil. A word about children hypertension and children with chronic kidney disease. The target blood pressure is less than 90th percentile. You know about escape trial and all. I'm not going into the details. Between CKD stage 1 and 3, you can use ACE inhibitors. You have to monitor potassium and creatinine. If the GFR is reaching between 30 to 50, then you should avoid ACE inhibitors and you should look for other drugs like calcium channel blockers and others. A word about evaluation and management of long-term management of these patients. So once you diagnose and once you have done the initial management well, that is not the end of the disease. That is the beginning of managing the disease, because then you have to annually follow these patients depending upon the situation. If the child has got normal blood pressure or say initial elevated blood pressure, you will have to look for all the aspects. What is the lifestyle of the patient? What treatment you have given? Whether the child requires ABPM, what diagnostic evaluation, and depending upon the disease, you will require to call this patient and see this patient in your clinic either between 1 to 2 weeks or 3 months, depending upon the disease and the stage. So that is extremely important. So this is the end of the slide. And again, this is an article by Dr. Rajiv Sinha. And this talked about the recent, I mean, these are all again now become quite old, the changes in the AAP guidelines. So to summarize, hypertension is not uncommon in children and adolescents. Measurement errors are frequent. Extensive investigation, though, are not necessary in every case of pediatric hypertension. Irrespective of medications, weight control, exercise, dietary sodium restriction are essential for blood pressure control. What they recommend is that for most children, salt intake of less than around 2 grams is required. 2000 milligram, and management should focus on BP control and not the dose and number of medications to control it. Important is that you must control the blood pressure, because if you do not control the blood pressure, then the child will have end organ damage, which will continue to occur during his adulthood and will lead to increased morbidity and mortality of the children. Thank you very much. I would now, if there are any questions, to answer.
So, uh, thank you, sir. It was a very great presentation and in a very simplistic form for postgraduate students to have a good insight. And there are few points which I would like to reinforce, especially for the outpatient clinics and pediatric patients, that all these normative values, as already sir told, are based upon the oscillatory methods. And most of the devices what we are using now in our IPDs as well as our OPDs are usually oscillometric. So it's mainly for the screening purpose. And once there is elevated BP or hypertension stages, we need to reconfirm it by the oscillatory method, and at least 2 to 3 readings have to be taken. And the average has to be taken for the pediatric patient because of the inaccuracy while we are diagnosing of a pediatric patient, plus the incorporation of the child. So these 2 3 things are mandatory. And even the AAP and all other guidelines have always recommended that it's not the first instance when we can confirm the diagnosis of hypertension. Even if in stage 1 or stage 2, we have to repeat the similar readings after a week or two, and then only we can have a confirmation about labeling the child as hypertensive.
Exactly, correct.
Specialized
Thank
area.
you, Dr. Ankit. And any questions, Dr. Neha?
We have two questions in the chat box. Sorry, I'm just traveling. That's why I think I'm just getting disconnected. So there was this: how to select intensive drugs. Does it depend on the cause? I think Dr. Saha has answered this very well. Sir, do you want to still say something on this question?
Yeah. So for postgraduate, I would, because the mistake which they commit, our postgraduate also in LH keep on committing those mistakes, is the common hypertensive emergency you encounter in most situations is post-streptococcal glomerulonephritis. This is very common, especially in now in winter months and all. And the patient might not have telltale signs. They come with hypertension, and very often we would see that the child has been started with enalapril. So that is one of the very important message which I want to give you. The mechanism of hypertension in post-streptococcal glomerulonephritis is it is a nephritis. So it causes hyperkalemia, and the mechanism why hypertension is occurring is the expansion of the intravascular volume. So the first drug which you should use in PSGN is furosemide. So you decrease the intravascular volume, you flush out the sodium, and you flush out the fluid, the blood pressure will settle down. If it doesn't settle down, then you add amlodipine. If you upfront add, you see if a patient has got a potassium of 5.5 and you start giving एनवास to the child, आपने 3 doses 4 doses उसको एनवास की दे दी, इससे पहले की पता चले तो उसका 5.5 का 6.5 हो जाना है, उसको एरिथमिया हो जाना है. So very important, question from postgraduate. So you already I presented it. So etiology is extremely important. Similarly, if we talk of outpatient department, if a child is having, say, obesity, if he's having migraine, and if he's having hypertension, I would better go for a beta blocker, to begin with. So etiology is extremely important. Similarly, if a child is having CKD, is CKD stage 1 to 2 or 3, and is also having proteinuria. So I know that for long-term renal protection, I would need antiproteinuric drugs. So I'll start here ACE inhibitors. So likewise, etiology is extremely important. So altogether, you will have to see whether the child is in, office setting or is having presented with hypertensive emergency or urgency, and what is the etiology. And based on that, you will diligently decide what to do.
Thank you, sir. Dr. Ankit, there's a question in the Q&A. Should we measure blood pressure in all IBD patients? NIH charts are okay for measuring blood pressure.
Okay.
For measuring blood
Right, ma'am. Your voice is breaking a bit, but I got the question. So, Dr. Saha has already discussed it in great detail. So, first important point is that any child who is above 3 years of age without any known complications or without any high risk rate should have an annual BP checkup. That is mandatory. Some European guidelines do say after 3 years they should have a BP checkup on every visit. But yes, we mostly follow the AAP guidelines, and a yearly checkup for a healthy child is okay. A child who is less than 3 years of age with risk factors like prematurity, any umbilical artery catheterization in preterm time, or any high risk drugs like steroids or drugs causing any hypertension, or any other solid organ transplants or other diseases like cardiac disease or something, then they need to have a BP evaluation on every visit, even below 3 years of age. But otherwise, it's a yearly annual visit. We should have a BP checkup. Second, NIH charts, yes, we can use, but most of the places here we are now following the AAP charts for screening as well as for the confirmation.
There is another question in the chat box which I saw was key if there is edema, GNN edema, where should we measure the blood pressure? So I showed you a nice chart of multiple things which is there in the recent International Society of Hypertension guidelines published in May 2026. So even if you are taking blood pressure above a single sleeve, you know, so that doesn't change much the blood pressure. So even if there is edema over the arm, because of if a child is having glomerulonephritis, there will not be much difference in the blood pressure measurement. So you can easily take, even in edematous child, you can take the right arm blood pressure and it won't change much.
One more question is there. Somebody has asked about that if only the systolic BP is high and the diastolic BPs are normal, then what should be done? So ideally, this is actually isolated hypertension. If only the systolic BP is high, and if it is not in urgency or emergency, then the first recommendation is usually lifestyle modification, low sodium diets, and exercises, weight reduction. So for isolated hypertension where only systolic BP is elevated a bit, these are the first line of management.
Exactly, agree with that. And however, if you are dealing with a child with hypertensive emergency, where there is end organ damage, there probably it is better to go by the systolic blood pressure. And this is very well dwell in an article recently in Pediatric Nephrology 2023. I also referenced it. So once you are managing a child with hypertensive emergency, look at the systolic blood pressure.
What about pulse pressure? I just want to barge in here, If there is high pulse pressure, a lot of discrepancy between.
So that will, sir, some way might tell you about the etiology of the hypertension where you're dealing with. But overall, the systolic and the diastolic blood pressure for management purposes, systolic and diastolic blood pressures.
Sure.
Dr. Abhijeet, very nice presentation. May I just ask a simple thing, one thing?
Yes, sir. Yes, sir. Please.
Very nice presentation. How commonly we are using ambulatory, you said, blood monitoring? It is being used routinely now in hospitals?
Sir, in most places where established pediatric nephrology division is there, they are using ambulatory blood pressure monitoring. And I think adults the adult nephrologists are routinely using ambulatory blood pressure monitoring. We have ambulatory blood pressure monitor, which we are using for last many years. But I think Dr. Ankit may be able to tell in how much in private practice people have started using it.
So we also have procured an ambulatory BP monitor around 6 months back. So and even the 2017 guidelines, they have started putting more emphasis now on ambulatory BP monitoring. And according to that, every child who is either elevated BP stage 1 or stage 2, especially in pediatric cases, the confirmation has to be made by ambulatory BP monitoring after either
before starting the treatment.
Before starting, because they give 2-3 episodes that after 3 months you measure a BP again, or after 2 weeks you measure, and then if you feel again the hypertension is persisting with your auscultatory and other methods, then ambulatory BP monitoring has been introduced as a modality of investigation, or whatever you can say, before starting the treatment. And in pediatric, definitely, sir, it makes a difference, because this white coat hypertension, the child starts crying when as soon as he enters a OPD or IPD uh, settings. So the home-based reports definitely help us good insight in choosing our drugs also, and having the confirmation also.
Is it available easily, or you have?
So, yes, it is
It's
available.
available, sir.
Yeah.
Only thing is you have to be
Yes.
careful, because a lot of Chinese products are available. So you will have to check a validated device.
Space Labs is good, sir. They have
Space Lab is
a
very
good,
good. Yeah.
yeah, they have a good validated device.
Okay, and finally, one more thing. We don't have an Indian charts, so we always follow the AP 2017 charts. So we don't have any Indian charts for this right now, till now, or any data we have.
Correct, sir. We have isolated regional charts, though we have in small number, but I think it will require an ICMR study on large number of patients. I think one is going on already. Dr. Girish Bhatt from
Bhopal.
Bhopal is, I think, undertaking a study, if I'm not wrong.
Thank you, sir.
Dr. Abhijeet and Dr. Ankit, there is a small practical question I wanted to ask about the pressure, blood pressure cuffs, We have only 3 standard sizes that are available: adult, infant, and small child, But, the sizes of the arms and length all vary so much, So what is the practical thing, and are more cuffs available from somewhere if you want to procure them?
Yes, sir, available, sir.
Yes.
Even thigh cuffs are available. So once you are procuring a blood pressure, especially multi-para monitor, we ask for 5 sizes of cuff. So even thigh cuffs are available. Only thing, you will have to insist them, and they will charge for it.
Yeah,
So
that's all right, but is it available?
Yeah.
The neonatal and preterm cuffs are also available.
Also available, sir. Everything is available, sir.
But in newborn, it's a challenge to measure the blood pressure, in the newborn.
So there are preterm cuffs also available, but
preterm
yes, you,
cuff
as
सब
sir said,
available हो गया है, sir. मल्टीपैरा मॉनिटर के साथ आप कनेक्ट करके ले सकते हैं, सर, ब्लड प्रेशर.
So there's a question in the chat box regarding isolated diastolic hypertension.
ma'am,
already discussed by Dr. Ankit. Yeah.
Okay, so we have taken all the questions from the chat box.
One question I saw, somebody asked कि long-term hypertension में क्या करना चाहिए? So you will have to monitor. I showed a chart given by AAP especially, and you should look for proteinuria. You should spot UPUC. You should do periodically, and if there is long-standing hypertension, then echocardiography also you will have to do and monitor the patients.
I would like to share that very important to blood pressure in children, because we get a lot of children. So this thing, something which I have noted in all PACs that we get it done for any child, they always take the blood pressure of any person who goes to them. So I think for pediatrics also, we should make it a mandate for children who is coming to us at least once a year. We should take a blood pressure, because that will actually give us an insight whether this child has a hypertension or not. Because we have picked up a lot of coactations like that. You just take the blood pressure, feel their lower limb pulses, and you can actually make out whether they have any problem ongoing. So I think it's very important to
Absolutely agree with you, and I don't allow any of the postgraduates to sit in my room along with me in OPD if they do not have the blood pressure cuff. I simply ask them that please come with your cuff. Otherwise, find some other room for without the blood pressure cuff. Because if you are sitting in an OPD and you are looking at 100 patients in one OPD, you must have a blood pressure cuff. Otherwise, you are going to miss cases.
For postgraduates and
Over to
CBC indices will see. Thank you, ma'am. Hello, am I audible?
Yes, sir.
thank
Yes.
you. Thank you.
Yes, yes. So such a wonderful topic is well covered by Dr. Abhijeet sir, and it's a routine practice in our daily OPD. And many times, even NABH accredited hospital also, they ask for the pediatric BP measurements, pediatric cases. Many times they ask me, are you taking the BP of the kids in OPD? So what I say कि हाँ 3 year plus में हम अपने OPD में डायरेक्टली लेते हैं, 3 साल से नीचे हमें लगता है तो हम उनको पेडियाट्रिक ICU में भेज के वहाँ पे NIBP से मेजरमेंट करा लेते हैं. Second is कि the cuff sizes rightly all are available. The only thing is the little bit efforts we need to put in to take the BP of the, because BP measurement in kids are the one of the most ignorant thing in OPD. टेम्परेचर लेते हैं, पल्स लेते हैं, रेस्पिरेशन होता है, बट बीपी नॉर्मली नहीं होता है. सिस्टर्स भी अवॉइड करती हैं, एंड समटाइम द चाइल्ड इज आल्सो एप्रेंसिव, क्राइंग एंड नॉट कोऑपरेटिव, सो लाइक दिस. Now, thank you so much for a wonderful topic covered by Dr. Abhijeet sir. Very well inputs by Dr. Ankit Mangla sir, chaired by Dr. Sunil Sehgal sir. Thank you so much, sir. Now, I welcome our Treasurer Cum Secretary like Dr. Ravinder Kumar sir. We welcome Dr. Pankaj also on the board. I think he just left. Now, put vote of thanks by Dr. Ravinder sir. Over to you.
Thank you, Dr. Dinesh. Thank you, Dr. Abhijit. Thank you, Dr. Ankit. That's a very crisp talk. I think hypertension nowadays is so much diagnosed because earlier I think it was one of the things that people used to there. It doesn't happen in pediatric age group. So thank you very much for very crisp talk. Thank you, Dr. Neha. And thank you, our guest faculty, Dr. Sunil and Dr. Lalit. You actually put in very good few questions, very practical questions. And thank you, Dr. Abhijit, for especially, I mean, your take-home message was very crisp. Okay, don't go much of extensive investigation, because what we have seen nowadays, if someone is having hypertension, and so many investigation has been done. Obviously, if it is required, obviously it has to be done. Secondly, you said 2 gram of sodium. Salt is a very important thing. Then you said still LSM, lifestyle modification, is we should not forget, because nowadays obesity is rampant in our country, and because of that probably hypertension is going on. And thank you all. Just one query to Dr. Neha. Although it is not about hypertension, you said you are traveling, but I can see behind high-rise building behind you, so it appears you are in air. So do you have satellite phone? How you are able to communicate?
That's the background of Akash, sir. That's
Okay.
the
No,
new
no. Although I know you are a high-profile pediatrician, so I thought you must be having a satellite phone that's still in air and still communicating. Thank you all. Thank you very much.
Thank you so much, sir. Thank you.
thank you, sir.
Thank you, Dr. Vasudev and Dr. Neha for inviting for this talk. Thank you.
Thank you, Dr. Neha. Thank you, Dr.
Thank you, sir.
Thank you. Thank you, everyone.